Okay. So after we have discussed the alcoholic liver disease, let's give some insight to other metabolic liver diseases as well, which may be seen in non-alcoholic patients. Some of them resemble closely the alcoholic steatohepatitis, but they are termed as non-alcoholic steatohepatitis or non-alcoholic fatty liver disease, which is an acquired condition and is a disorder of metabolism. Some pathogenesis of this will be discussed. Similarly, some inherited disorders like hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency, and last but not least, a very common condition. Almost every child who is delivered preterm is having some sort of jaundice, these neonatal hepatitis, which are and some rare inherited diseases will be discussed subsequently. Non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Although these terms are synonymously used, but again, they are reflecting a spectrum of changes. If there is only steatosis, the term of non-alcoholic steatosis or non-alcoholic fatty liver disease is usually preferred. But when it is associated with some sort of inflammatory response eliciting within the hepatocyte, hepatic parenchyma, and resulting in some sort of fibrosis, leading to ultimately cirrhosis, the term of NASH, non-alcoholic steatohepatitis, is commonly used. These are basically a spectrum. It is not a single pattern disorder. It is a spectrum of disorders that have in common the presence of hepatic steatosis in individuals who do not consume alcohol. So the history taking is really very important if you are to differentiate between NASH and ASH, that is non-alcoholic steatohepatitis, and alcoholic steatohepatitis. Insulin resistance is the key factor involved in the pathogenesis of non-alcoholic steatohepatitis or non-alcoholic fatty liver disease. From obesity or an overabundance of high caloric food intake with lack of physical activity, diminished exercise, and some genetic mechanisms, they are involved in the pathogenesis of non-alcoholic fatty liver disease due to insulin resistance. There may be some dysfunctionality encountered in the adipose tissue as well. Uh, Beside insulin resistance, hepatocellular oxidative injury, which is resulting in liver cell necrosis and inflammation. A subtle sort of injury, usually, you know, in those cells which are already laden with the lipids, that is, steatosis is there, and these cells, they may undergo some process of injury, subtle injury, due to increased production of cytokines by the resident macrophages like TNF-alpha, interleukin-6, in the cells which are present in close vicinity to fat-laden cell hepatocyte, as they are very highly sensitive to lipid peroxidation product. So these two are the important pathogenetic mechanism involved in the causation of non-alcoholic fatty liver disease. Steatosis may be considered phenomena associated with, it is defined as the accumulation of fat within the hepatocyte. It may be pathological steatosis. Usually it is pathological steatosis, but in some conditions, it may not be associated with any over disease process. So pathological steatosis in particularly is defined as involving more than 5% of hepatocyte are having this steatosis. Um, if on average basis, an ultrasound scan is being done for on mass level, then you would see in people older than 40 years, this is usually fatty liver is or fatty infiltration of the liver is usually seen in a majority of the patients. And this is again referring to, lack of exercise, high caloric diet intake, obesity, or pre-obese conditions. So these are the basically factors which may involve in the pathogenesis of non-alcoholic fatty disease. The fat is accumulated within the liver, usually in the form of a small, medium, and large droplet of fats, mostly triglyceride. They are accumulating in the liver cells. Ultimately, they coalesce with each other to form a larger fat droplet, and the appearance of hepatocyte changes from that of polygonal or multigonal to a round to oval cell with the peripherally placed nucleus. A signet ring-like appearance is being shown, and adipose tissue or adipocyte-like appearance is usual. It resembles quite that. So basically, this is in fact a liver cell which is laden with the lipid and is more liable to undergo injurious process. In earlier stages, there is no appreciable hepatic inflammation or injury or scarring, although liver enzymes are usually raised, especially this ALT, and it makes, raised ALT. It gives an impression that the person is suffering from some uh, like viral hepatitis. So again, this non-alcoholic fatty liver disease is the diagnosis of exclusion. When you have excluded all the viral causes of hepatocyte fatty infiltration, you have excluded alcohol abuse, and still the person is having these fat droplets within the hepatocyte, the person is said to be suffering from non-alcoholic fatty liver disease. Almost the features are same as that of alcoholic steatohepatitis. Even the morphological features are almost similar. If you see the microscopy of the liver or ultrasound scan of the liver, it will give you the similar picture as we usually see in the cases of the alcoholic steatohepatitis. So the only difference is, that has to be kept in mind, that history should reveal the difference between alcoholic steatohepatitis and non-alcoholic steatohepatitis, as there will be no history of alcohol consumption in cases of non-alcoholic fatty liver disease, which is usually appearing like these fat vacuoles appearing in the hepatocyte, pushing the nucleus to a site, converting these polygonal or hexagonal hepatocyte into round to oval cells with peripherally placed nucleus, peripherally peripherally placed nucleus, and hepatocyte are acquiring a more adipocyte-like appearance. Again, if we stain this slide with this tissue with the mesenterichrome stain, in the earlier stages, we see this perivenular fibrosis, which is extending into the pericellular fibrosis in a chicken wire pattern, as we see in alcoholic steatohepatitis. And then gradually, this is, chicken wire pattern fibrosis, which is typical of steatohepatitis. If there is hepatitis, fibrosis followed by inflammation, or maybe if bland fibrosis without any evidence of the inflammation. There are certain genetic factors as well as some environmental factors which are supposed to, be associated with progression of a disease from in a normal level liver to inflamed or fibrosed liver. So if you see, a normal liver will initially go through the process of fat accumulation or steatosis. Certain genetic predisposition, like a single nucleotide polymorphism, especially of an enzyme called PNPLA3. This is basically, again, a hydrolase enzyme, which is present in the liver. It is also present in some other tissues as well. But if it is highly reactive, the mutation resulting in, a gain of function mutation resulting in increased synthesis of this enzyme by the proteins P and PLA3 due to single nucleotide polymorphism, then one can have this disease due to which enables the patient to accumulate fat without metabolizing it. The metabolizing capability of the liver is compromised, and the liver is laden with fat. Certain environmental factors definitely they do work in conjunction with these genetic predisposition, like lack of activity, obesity, any metabolic syndrome, especially the insulin resistance, which also leads to diabetes mellitus, and a diet which is high in is having higher calorie intake, high calorie diet, like fast food, which we usually consume. And if these things are there and they are backed up by the genetic predisposition, then the person would develop accumulation of fat, steatosis in a liver, resembling the alcoholic steatosis. But this is again, uh, this there will be no history of alcohol consumption. Gradually and over a period of time, this steatosis, it leads to hepatocyte injury, ultimately inflammation or fibrosis, resulting in what is called as steatohepatitis or steatofibrosis. This is a process similar to what we have discussed in alcoholic steatohepatitis. Almost the picture is quite similar. Sim, uh, there will be, activation of the stellate cells, lipid peroxidation, gut microbiota or endotoxins may induce some injury into the hepatocytes. Free fatty acid entry from the peripheral stores of the fat is usually mobilized, and increase entry of the free fatty acid occurring within the hepatocyte. And ultimately, there will be accumulation of fat and subsequent inflammation resulting in fibrosis. But over more than two-thirds of the patient, there will be only isolated fatty liver with none to very minimal progression to cirrhosis, no fibrosis, no inflammation, only bland steatosis will be there. So these patients are not at any risk of death due to chronic liver disease as compared to the general population. The increase of death is not increased, and the liver it remains functional throughout their life process. But in the patient, when it is developing non-alcoholic steatohepatitis, in almost 11 or almost 20% of the patient, but over a period of time, let's say over 15 years, but this period may be significantly variable, it develops into NASH cirrhosis, non-alcoholic steatohepatitis, resulting in cirrhosis. Again, in the earlier stages of the disease, this NASH cirrhosis is compensated. Then later on, it progresses and involves more and more parenchyma of the liver, resulting in decompensation over a period of, let's say, 8 years. And then this may be associated with an increased risk of hepatocellular carcinoma. As we see in cases of cirrhosis, this is a very, feared complication of cirrhosis to develop hepatocellular carcinoma. So usually we say, okay, there are two hits important in the pathogenesis of non-alcoholic fatty liver disease or NASH. And in the first hit, which is usually seen in genetically susceptible individual, obesity and insulin resistance and increased entry of the free fatty acids convert this normal liver into liver laden with lipids, fatty liver. We call it as non-alcoholic fatty liver disease. And 10 to 20% of these individuals due to second hit phenomena. You see, this second hit phenomena maybe due to gut-drive endotoxins or inflammatory cytokines, oxidative stress, mitochondrial dysfunction, ER stress, anything leading to injury of the hepatocyte, eliciting an inflammatory response, converting this inflammatory response or transforming this acute inflammatory response into a chronic one, and then followed by fibrosis would lead to non-alcoholic steatohepatitis and ultimately cirrhosis. Insulin resistance, it not only increases the blood glucose level, but also causes increased entry of the fatty acids within the liver, especially from the adipose tissue, and excess dietary lipids, which are absorbed from the gut, and they are also entering into the fatty acids, into the hepatocyte. Once they are in the hepatocyte, then they are metabolized. Metabolism may occur in the form of synthesis of lipoproteins, or they may be oxidized to ketone bodies, or process of gluconeogenesis may be there. But when the capability of the liver is compromised, in metabolizing these substances, and especially these free fatty acids, the free fatty acid, then they tend to accumulate within the hepatocellular, in the cytosol of the hepatocyte, forming a smaller, very small and mini ultra micro vacuoles. Finally, these vacuoles may coalesce with each other to form a large vacuole, microvesicular to macrovesicular steatosis. Anything can happen in these things. And this is needless to say, that all the patient of non-alcoholic fatty liver diseases, they are not entering into the non-alcoholic steatohepatitis. Only those who are having a second hit, they are developing non-alcoholic steatohepatitis. Morphology and clinical course, it remains same as that of the alcoholic steatohepatitis, and we have discussed in the case in the lecture on alcoholic liver disease. Another disease which is very important and is inherited usually due to excessive iron absorption and deposition in the parenchymal organs like liver, pancreas, heart, endocrine glands, joints, bone marrow. This is called as hemochromatosis. There is a slight difference between hemosiderin and hemochromatosis. Hemosiderin is the stored form of the iron. So when there is excessive iron intake, or excessive iron is there therapeutically induced, or uh, in certain cases, it may be coming from the hemolyzed RBCs. But this hemosiderin, which is the stored form of the iron, is deposited. This is called as hemosiderosis. But in the excessive condition, when a hemosiderin accumulation activates the resident macrophages, and macrophages then they start secreting certain pro-inflammatory and pro-fibrotic mediators, then it results in the organ damage. Liver gets injured when there is lipid peroxidation through iron catalyzed free radical reaction. Iron is one of the, if you remember the knowledge of general pathology, so transitional elements which can donate one electron or can accept one electron, they are an important source of free electron, and this free electron converts a substance, a stable compound, into a free radical. So free radical generation through these transitional metal is quite common, as we see in the cases of the metalloproteinase or metalloproteins, like liver or liver containing proteins. This result in hepatic stellate cell stimulation and interaction of the reactive oxygen species and iron with DNA. These reactive oxygen species not only interact with the DNA, but they cause phospholipid peroxidation, resulting in breakdown of the cell membrane, injury to the cell membrane, and they cause oxidative modification of the proteins, and they are interacting with the DNA as well. So hemosiderosis may be hereditary due to mutation of certain genes, which is not a common feature, not commonly seen. We usually see the patient having some, secondary cause of hemosiderosis. Hemosiderosis due to some known cause, secondary to some other condition. like in parenteral iron overload, like as in cases of transfusion or anemias, different anemias or iron dextran injection, when there is ineffective erythropoiesis with increased erythrocyte activity, when there is increased oral intake of iron, or in certain chronic liver disease, neonatal hemochromatosis, like these hemochromatosis are secondary. Secondary, meaning they are acquired during life process. They are not primary. The most important morphological feature is the deposition of hemosiderin. Usually in the parenchymal organs, especially liver, it may be accumulated in the pancreas, pituitary, adrenal, thyroid, joints, skin, or any other gland. In the H&E examination, we usually see this golden yellow hemosiderin granules in the periportal hepatocytes, and they may extend throughout the lobule, then into the bile duct, ultimately into the Kupffer cells. Typically, the inflammation is not present, but in excessive condition, there may be fibroceptor. They develop slowly, leading to a small shrunken liver. Ultimately, what is called as cirrhosis may be associated with cirrhosis and fibrosis. Fibrosis in some other organs, like in the pancreas, like in the myocardium, or even in the thyroid gland or joints, where they are causing ankylosis. So if we stain the tissue with the iron stain, Persian blue reaction, the iron deposits are usually occurring as blue dots within the liver parenchyma. So whenever you see a liver biopsy, you should be looking for iron stain or Persian blue reaction in order to see if there is any degree of hemochromatosis, yes or no. Initially, there will be enlargement of the liver. Ultimately, the liver may be shrunken when the cirrhosis develops, associated with abdominal pain, skin pigmentation, deranged glucose homeostasis or diabetes mellitus. If the pancreas is involved, if the myocardium is involved, one can have cardiac dysfunctions. If the joints are predominantly involved, atypical arthritis may be there. So there, the clinical features, they tend to vary from organ or to organ, which organ is predominantly involved, and what is the severity of the involvement. So both these conditions will determine the variable clinical features, which are usually a common feature of. But whatever the organ is involved, if we see it in the microscope and stain it with the Persian blue stain, it will give a positive blue color. All the cases of hemochromatosis. Similarly, we have another disease which is called as, Wilson disease. Basically, it is the failure of to excrete copper in bile due to inappropriate incorporation of copper into ceruloplasmin. Ceruloplasmin is a copper-containing protein. So copper, if it is not being sent into the ceruloplasmin, it is not being carried away, and the copper will get accumulated in different parenchymal organ. Mostly this Wilson disease is a genetic disorder. It is a hereditary disorder. It is an autosomal recessive disorder with the mutation of ATP7B gene. And this results in the, copper is not being taken up by the ceruloplasmin. So the copper starts accumulating within the parenchymal organs, and when the levels reach to a toxic point, then it will induce definitely some organ damage. Liver injury due to deposition of copper is caused by promotion of free radical formations, and it may bind with sulfhydryl group of these cellular proteins, making them, non-functional, uh, causing denaturation of this protein and displacing metal from the hepatic metalloproteinases. So, chances of getting injured by free radicals, the reactive oxygen species, it becomes more and more. Um, Again, the morphology of the liver in particular, in cases of, this Wilson disease is variable with mild to moderate fatty change with focal hepatocyte necrosis. In very rare cases, it may lead to acute or fulminant hepatitis. But moderate to severe chronic steatohepatitis is usually the result, leading to cirrhosis, especially in those people who survive the acute or fulminant hepatitis. toxic injury to brain may be seen, or the most characteristic finding of a KFR ring, Kessler-Fleischer ring, which is usually seen in the eye in the form of a brown ring at the periphery of the cornea due to deposition of this copper. This KF ring, Kessler-Fleischer ring, is seen in the, in the cornea. In the liver, there is deposition of this copper within the this hepatocyte. Achha, this copper is usually a golden brown pigment, and at some instances it may resemble the bile salt. So it may be mistakenly seen the bile salts, or it may be giving a sign of cholestasis rather than the copper deposition. So a typical stain, which is called as Orcine stain, is usually used for the diagnosis of these, you know, these copper deposition within the hepatocyte, which usually gives a brown deposition, particular brown deposition or serous stain, which will not be positive in cases of the cholestasis. If this is bile, this will not be positive. Ultimately, it leads to, periportal portal inflammation, then periportal inflammation, fibrosis, and ultimately complete or incomplete nodule formation and cirrhosis. So it may cause hepatomegaly, jaundice, acute or fulminant hepatitis, and cirrhosis. Then cirrhosis would have its all the complication like portal hypertension, ascites, bleeding esophageal varices, hepatic encephalopathy. In the bone, it may lead to rickets or arthritis, and the in the RBCs, it may cause hemolysis in the blood. It may cause hemolysis. It may get deposited in the kidney, parenchyma of the kidney, or in the myocardium, in the eye, in the brain. So a lot of clinical features, a variable number of clinical features may be seen. So with this, we are finishing with this metabolic liver disease. And if